All right, so in our idiopathic patients, although we don't know what causes it, there tends to be some family history sometimes. Oftentimes male to male is something I see very commonly. My dad had it, now I have it, I'm a male, so we kind of see that. Or, my mom had it, and my other siblings also have it. So getting that good family history in your patient is very helpful. Environmental, again, a lot of times these patients have exposures to cigarette smoking or occupational exposures where they're working with chemicals, fumes, powders, things like that. And this could be decades ago that they had this exposure. They haven't smoked in 30 years, but they tend to have that history backing them up. And then behavioral histories, which I think kind of goes with the smoking history as well. All right, so here's our little pathophys here. So when you think about simplified version of the lungs, they are straws with balloons on the ends, right? So we've got the airways, which are the straws, the balloons, which are the air sacs. The alveoli are elasticy, they're stretchy, and they're surrounded by a fishnet of capillary bed. And that's where the magic happens and gas exchange happens to get oxygen into the blood supply. Well, the tissues between are the interstitium. So is kind of the glue that's kind of holding everything else together. And that interstitium needs to be very thin and very compliant for the lungs to work like they should and to be able to exchange gas. And what's happening in these patients is that there is this inflammatory process happening in the interstitium. You guys can see over here, like in this space here. And I know it's very hard to see from very far away, but it's talking about fibroblasts, which are normal circulating entities that we have. These fibroblasts, TGF-beta and microfibroblasts, they're in circulation, but what happens for whatever reason is there's some sort of insult that turns them on and then starts creating fibrosis in this space. And that then leads to thickening of the interstitium for name your reason. Again, it could be the parrot they have in their house. It could be the autoimmune disease that's flaring or not well controlled or not identified yet. It could be, again, idiopathic. We don't understand about genetics yet with IPF. And then as that interstitium thickens, a couple of things happen. One is it becomes too dense for gas to exchange in those capillary beds. Another thing that happens is the lung loses its elasticity and compliance, and so it becomes stiffer, and it's not able to take the volume of air into those spaces, into the alveoli like it has been designed to do. So, progressive pulmonary fibrosis. So this PPF is where a lot of the research has gone over the last several years. How we define PPF, progressive pulmonary fibrosis, and this could be any underlying interstitial lung disease, okay? Hypersensitive pneumonitis can develop into a fibrotic phenotype. NSIP can progress into a fibrotic phenotype that can be progressive. IPF is generally progressive. So how we know it's progressing is we're watching their FVC. Again, forget about the one. We're looking at their FVC and we're looking at their DLCO, their diffusion capacity. And if their FVC declines by 5% or more in 12 months and or their DLCO declines by 10% or more in 12 months, we consider that a progressive phenotype. Another way that we also look at it is the radiology findings. So I'm in a community setting. I'm not at a university setting or an ILD center. You guys have, by the way, some amazing pulmonary APPs here that are going to be in your workshops that are at big, like Cleveland Clinic's ILD Center and National Jewish and all sorts of great places. They do practice a little differently than community practice only because we don't have as many resources as they do. In community practice, we repeat CT imaging for worsening symptoms and or lung function. So just so you know, if you're not working with a big system and you have a community pulmonologist that you're working with, they may not be getting serial imaging just because, if they have a smoking history, they might be doing lung cancer screening, not the best imaging for interstitial lung disease. But usually, to save cost, time, radiation exposure, we're not doing as many CT scans as I know my colleagues are doing. But if they do show progression of disease that you can visually see on the scan, that is concerning for a progressive phenotype. And you need to have two of those issues, either worsening symptoms and lung function symptoms and CT imaging, or PFTs and radiology are worsening. So this is just an example of worsening disease. So this is a patient with IPF. Again, you can kind of see at the bottom, so right lung, left lung, diaphragm, left diaphragm. And we are seeing this coarsening here at the bottom, kind of a honeycombish-like appearance, and it's kind of creeping up the edges here and into the fissure, this right fissure here. We can see it's very coarse. I mean, usually the fissures are pretty smooth. We can identify them, but they shouldn't really stand out at you. But this fissure definitely is very thickened here. And then again, just looks very rough on your way up. This looks nice and smooth at the very top, very nice and smooth. But we would call this reticulation happening in these areas. And mainly basilar predominant. This patient, 4 years later, now look how, I don't know if you can appreciate how far back you are, but how rough this lung now looks. This fissure is getting even thicker, thicker here, extending out. Now even some honeycombing happening in the left lower lung that we didn't see previously. And again, very coarse on our imaging here as well. All right, exacerbations. So when do we use oral corticosteroids? We tend to use them when they acutely exacerbate. Depending on what's driving the interstitial lung disease, oftentimes we may start them initially on a prolonged course of oral corticosteroids. And if we can't wean them off or they're continuing to progress, we will add on a steroid-sparing therapy, some sort of immune modulator. Then we try to wean the prednisone or the oral corticosteroid off, and because of all the long-term side effects of oral corticosteroids. Oftentimes if they're seeing rheumatology and the rheumatologist wants them to be on steroids, I'm like, I don't have to prescribe it, but you're still getting it and you're getting some benefit. Oftentimes patients do feel better on them. We didn't tend to use them very sparingly in these patients. Patients who have purely fibrotic disease don't tend to really respond to them very well unless they're having an acute exacerbation, and even then response is pretty low. We don't usually use it as maintenance therapy. Again, we try to give them something else that is steroid sparing. When we do combine it with some other therapies, before we had antifibrotic therapies, a lot of our trials were showing more harm than good, and actually less survival in patients who were on long-term oral corticosteroids. Especially azathioprine. So early on, patients did have benefit in the combination of oral corticosteroids with azathioprine. Probably, my guess is that they were getting a lot of the acute inflammation down, and that's why patients were initially doing better. However, they stopped the trial early because patients were dying faster in the treatment arm than they were in the placebo arm. And so we try not to combine those. Cyclophosphamide and mycophenolate are therapies that we definitely consider in these patients.